In this lecture, we will discuss left anterior descending coronary artery occlusion, including the regions of the heart potentially affected, as well as their corresponding EKG features. The left anterior descending coronary artery, or LAD, supplies the anterior two-thirds of the interventricular septum, which is referred to as the anteroseptal area. It also supplies the anterosuperior wall, which is commonly referred to as simply the anterior wall of the left ventricle, as well as the apical part of that lateral wall. Okay, the LAD may stretch to the inferior wall and supply most of the apical region, that is the infero-apical area, and sometimes it may be so long that it supplies a significant portion of the inferior wall, which is referred to as a wraparound LAD because it wraps around the apex. Okay, so let's look at the LAD here. We're saying it supplies two-thirds of the interventricular septum. So again, the anteroseptal region. So here is our aorta, okay, where we have our LMCA, left main coronary artery, gives rise to the left circumflex, and here's our LAD, okay. Our left anterior descending artery supplies this interseptal region, okay, our interventricular region between our ventricles, okay, from these septal branches, our septal perforators, and then we have the anterior portion of the heart, which is this region here of our left ventricle being supplied, the anterior superior. We have the apical part of the lateral wall, okay, this region here being supplied, as well as the infero-apical area. Okay, the infero-apical, the area here is also supplied, and if the LAD actually comes more distally and wraps around, it may supply the inferior portion, that back portion of the left ventricle as well. Okay, so again, left anterior descending artery is coming off the left main coronary artery. Okay, so as you would expect, occlusion of the LAD can cause an anterior MI. It's covering the anterior portion of the left ventricle. The EKG changes and extension of the infarction really depend on the occlusion site within the LAD. For instance, the more proximal the occlusion, the greater the amount of infarcted tissue and the more pronounced the EKG changes will be. We may see ST elevation in leads V1 through V6 and often leads 1 in AVL. Now leads 1 in AVL may show ST elevation because the diagonals given off by the LAD supply the apical part of the lateral wall, and there's pretty much always reciprocal ST depression in leads 3 in AVF and sometimes 2. Okay, so let's take a look at a proximal occlusion of the LAD. Okay, and this causes massive infarction of the basal parts of the anterosuperior wall, the lateral wall, as well as the interventricular septum. As we mentioned earlier, the more proximal the occlusion, the greater the amount of tissue involved and the more leads that will show ST elevation. Now, if the occlusion is proximal to the first septal perforator in first diagonal branch, we will see ST elevation in leads V1 through V6, 1 in AVL, along with reciprocal ST depression in the inferior leads 2, 3 AVF, and sometimes lead AVR. Now, we can have also, in this case, with these proximal occlusions of the LAD, new onset right bundle branch block. Okay, so it's common to see that in this sort of occlusion. So let's look at this occlusion here. Okay, so I'll erase this. And now we're talking about occlusions within the LAD. Remember, we mentioned we're going to try to identify and see if we can see where these are coming from within the artery. So here's our LAD, okay, and we're going to talk about the proximal one, which is this one here. And again, it's coming before our first septal perforator. So these are our septal branches here. So imagine this one here, and then our diagonal branches. Here's D1, okay, coming off that way. So we have it occurring before these ones, and because of this, okay, we're saying the sooner it comes in the LAD, so this is clear, if it's coming sooner, imagine all this region is not getting any oxygen, so it's going to become ischemic and potentially infarcted if it's not opened up or recovered. Okay, so the sooner, the more proximal we have the lesion, the more stuff distally, the more myocardium distally will be affected. Okay, so if you look here, here's the proximal LAD. We're talking about this one here, and we see that basal parts of the anterior wall, the lateral wall, and sometimes the interventricular septum supplied by those septals can be affected. Now, if it's proximal to both of them, okay, we have ST elevation in V1 through V6. So here's V1, V2, V3, V4, or V4, V5, and V6, okay? So our precordial leads, so V1 through V6, we'll see ST elevation, okay, because they're overlying that region. And we'll also see ST elevation in leads 1 in AVL because of those diagonals. Here's AVL and 1, okay? So here's one in AVL. So all those leads highlighted so far, we'll see ST elevation, and then we'll see reciprocal ST depression in the inferior leads, okay? Remember, when we talked about inferior infarcts, we said we saw reciprocal changes in one in AVL. Now we're pretty much seeing the opposite. Now with the infarct being in one in AVL, seeing ST elevation, these inferior leads that are reciprocal to them will show inferior or reciprocal ST depression, okay? So reciprocal ST depression in those leads as well as in AVR. So AVR would sit over here, and obviously it's going away from all the stuff that's going on in this region, so we can see reciprocal changes in lead AVR. Okay, remember this sort of proximal LA or occlusion is also associated with this new onset right bundle branch block. Okay, now if the occlusion occurred between the first septal perforator and the first diagonal branch, it will usually spare the interventricular septum, and therefore ST elevation in lead V1 will often be absent. Okay, so remember, let's just erase some of this. Now we're looking at that second point there, okay, the second point at this point, and here it's between actually the first perforator, okay, and that first diagonal branch. In this case, if the first perforator comes off somewhat before it and is able to feed this interventricular septum, it won't be affected. And in that case, we won't see ST elevation in lead V1 in this region here, okay, and sometimes maybe V2, but V1 often won't show ST elevation, okay. Now, what we also have affected here is everything else. So you pretty much have the same changes as we saw with the proximal lesion, but now in this case, we just don't have ST elevation changes in V1. Okay, so between the first septal and first diagonal, it often spares the interventricular septum. So we have all these changes that we mentioned above. The only exception is we don't see it here in V1. Okay, so it's absent. ST elevation is not seen in lead V1 that's overlying that septal region. Okay, so what if we have a more distal occlusion of the LAD? Well, occlusion distal to the first septal and first diagonal branches will spare the basal parts of the anterior wall. Therefore, the ST vector will be directed more inferiorly. Okay, the ST elevation can be seen in leads V2 through V6 without ST elevation in leads V1, 1, or AVL. In addition, there will be no reciprocal ST depression in the inferior leads 2-3 AVF or lead AVR. So let's take a look at this. Okay, we'll erase some of this stuff here. Okay, now we're looking at that third dot in the artery, which is this one here. So we're getting more distal along the left anterior descending artery. Okay, and what we see here is as you're coming down, you're actually going to be coming more inferiorly. So now our vector is actually going to be going downwards. Okay, our ST vector into more of our inferior leads, okay? And because it's going more inferiorly, we're not going to see the reciprocal changes in those inferior leads or in AVR as well, okay? We're going to see ST elevation in leads V2 through V6, all right? So we're getting in this region here, V2 through V6, all right? So here's V2, V3, V4, V5, and V6, okay? And not in V1, okay? So again, we're sparing the interventricular septum because we're getting so far down. We have our septal perforators that are able to feed it. So V1 is not affected, okay? And also, we're saying that the basal parts of the anterior wall are being affected. So this region here is certainly being affected. The ST vector will be heading this way as well as somewhat inferiorly. So we won't see the reciprocal changes in the inferior leads, but instead only ST elevation in leads V2 through V6. All right, now what if we have an occlusion in a long LAD, which we refer to as a wraparound LAD? In this case, we said we would have significant inferior wall involvement. Therefore, you would see ST elevation in the inferior leads 2, 3, and AVF, and if the lesion is very distal in this long LAD, you can imagine how it could be somewhat deceptive and resemble an inferior infarct from an RCA or right coronary artery occlusion. Okay, remember when we talked about right coronary artery occlusions, one of the most common is inferior wall involvement. Okay, now we're saying if we have this LAD, okay, here's our LAD here, imagine that it stretches all the way around. Okay, so it stretches all the way around to the inferior portion. So it's wrapping around and supplying the inferior wall, similar to what that PDA would be doing it from coming off this right coronary artery. Remember, right coronary artery in right dominant patients comes down and often supplies this PDA, supplying the inferior portion of that left ventricle. Now, if we have this wraparound LAD that's coming around and supplying the inferior wall of the left ventricle, you can see if we have a distal occlusion somewhere here with a wraparound LAD, we can get similar findings to an inferior infarct. Okay, so imagine our lesion is here. Okay, this area is occluded. Everything after it, all that stuff that's supplied by that wraparound LAD will be affected, including the inferior region. And because of this, you can see how it would mimic and seem like we had a right coronary artery involvement. Okay, and that could be really deceptive and mimic an inferior infarct from the RCA. So again, the changes we see with these inferior infarct are ST elevation in leads 2, 3, and AVF. Okay, so our inferior wall being affected. So here are the inferior leads. Okay, you may see reciprocal changes in 1 and AVL, as we saw in inferior infarcts. Okay, so hopefully that makes sense. But notice this is still involvement of the LAD. This is a wraparound LAD. So that's something to consider if you see an inferior infarct. Okay, always keep that one in mind, that this patient may actually have a wraparound LAD that's supplying the inferior wall and be the one that's involved in this case. Okay, now a few final points that can help localizing lesions include the following: occlusion in the first diagonal branch. Okay, so where's our first diagonal branch? Okay, which would be this one, D1. So if you have an occlusion in this first diagonal branch, you may actually see ST elevation in leads 1 and AVL without any significant ST elevation in other leads, and reciprocal ST depression in the inferior leads. Okay, so again, 1 and AVL, reciprocal changes in 2, 3, and AVF. Now, occlusion of the first septal perforator, which is this one here, okay, that first septal branch coming off, this can cause ST elevation in leads V1 and V2, which are the ones over that septal region, as well as reciprocal ST depression in leads V5 and V6. Okay, so our left lateral leads V5 and V6 over here, okay, near 1 and AVL. And you can also see reciprocal changes in the inferior leads, 2, 3, and AVF at times. In addition, cardiac MRI has recently revealed that the formerly believed septal infarct, when there's ST elevation in V1 and V2, may actually be more of an apical infarct instead. So just a few extra notes for you. Now let's review what we discussed and before we end here. So again, the LAD, the left anterior descending coronary artery, supplies the anterior 2/3 of the interventricular septum, which we consider the anteroseptal region or area, and the anterior superior or anterior wall of the left ventricle, the apical part of the lateral wall, and sometimes the infero-apical area, as well as the inferior wall if we have that wraparound LAD. Now LAD occlusion, okay, there's quite a bit here. Typically we'll see an anterior infarct, the region that it often supplies. So generally we'll see ST elevation in V1 through V6, 1 in AVL, and reciprocal changes in those inferior leads. Okay. Now with a proximal LAD, so that meaning the closer, the sooner portion of this left anterior descending artery, if that's occluded before the first septal and first diagonal, we'll see ST elevation and V1 through V6, 1 in AVL, as well as those reciprocal changes in 2, 3 AVF, as well as sometimes AVR. Okay, and remember, this one's associated commonly with right bundle branch block, that new onset. Now, if it's between the first septal and the first diagonal branch, this will often spare the interventricular septum, okay, because now that septal branch is able to feed the septal area, and we will often not see ST elevation in lead V1, but everything else will still remain the same. Now, if it's distal to those branches, both the first septal and the first diagonal branches, it will again spare the interventricular septum and also spare the basal portions of the anterior wall. Okay, remember when we talked about the basal, mid, and apical regions of the left ventricle. Go back and review that if you are not recalling that. Okay, so this one's sparing the basal portions of the anterior wall. In this case, now the ST vector will be directed more inferiorly, so instead of seeing those reciprocal changes in those inferior leads, we're only going to see ST elevation in leads V2 through V6. Again, not in V1 because we have that first septal perforator that's supplying the interventricular septum. Okay, now we talked about the wraparound LAD. In this case, we have the inferior wall that could be involved, okay, where we'll see ST elevation in inferior leads. And again, this could mimic an inferior MI from an RCA, or right coronary artery occlusion. So that's something to keep in mind on your differential. Now, first diagonal branch, if that's affected, we'll see ST elevation in 1 and AVL, and in this case, reciprocal changes in those inferior leads. If the first perforator is occluded, this first septal perforator, we'll see ST elevation in V1 and V2, as well as reciprocal changes in V5 and V6, as well as those inferior leads. Now, there's also that we mentioned with this as cardiac MRI has been showing, is that what we used to consider a septal infarct with ST elevation in V1 and V2 actually appears to involve more of the apical region as well. Okay, so there's some controversy on that today. Well, that's the end of this lecture. We discussed left anterior descending coronary artery occlusion, including the regions of the heart potentially affected and their corresponding EKG features. I hope you learned something.